Hey, future respiratory therapist. So, got a request to do a quick breakdown on dynamic versus static compliance. And this is a great request. This is a great question because as students, and respiratory therapists, it's greatly important for you to understand these two terms. These are terms that we evaluate. These are measures and things that we evaluate on a daily basis that we trend that truly set us apart from other disciplines. So you talk about nurses. You get a lot of these conversations. If you saw my Instagram post back a couple of days ago, you may have seen where somebody said, what can an RT do that a nurse can't? And from a legal perspective, the answer to that is probably nothing. Okay. But what we can do is have a greater understanding of the things that we're doing all day long. We are taking care of ventilator patients. The nurses are taking care of ventilator patients. And these are just two examples of things that we have a greater understanding of because we spend 2 to 4 years learning this and crafting these concepts, okay? So very rarely, I'm not sure if I've ever heard a nurse speak about dynamic or static compliance. I've never heard a conversation with a physician where a nurse says, hey, we need to do this because we have a worsening static compliance. Or we need to give this drug because we have a worsening dynamic compliance. I've never heard those words spoken ever. And that's our job. That's the difference, okay? It's not good or bad, it's just different, okay? It's what makes us valuable. So understanding these terms is important, okay? So when we talk about compliance, you're talking about the change in pressure when a given volume is delivered. Okay, so we're going to talk about the formulas here in just a second. But before we get into the formulas, I just want to give some quick facts about dynamic versus static compliance and what makes them different. Okay, so I'm going to start with static because it tends to be it's simplistic. It's to me it's an easier concept because it's just one factor. Okay, so when you're talking about static compliance, you're assessing the compliance of the alveoli only. Okay, this isn't a complete assessment of the change in pressure for a given tidal volume, including the airways. This is just alveoli only. Okay, so that's the first thing you need to know. When we talk about disease processes that might affect your static compliance, you're talking about only parenchymal lung diseases. So you're talking about diseases that only affect the alveoli. Okay, so examples of that is pneumonia, pleural effusion, atelectasis. These patients would present with a decreased static compliance. Okay, now on this other side we have dynamic compliance. And when you talk about dynamic compliance, you have to understand that you're talking about the total overall pressure the total overall change in pressure for that given tidal volume, including the pressure that it takes to get through the airways. So air moves in, goes out to the lung parenchyma, and comes out. It takes pressure to get through the airways, okay? And that's where dynamic compliance comes in. So now we're talking airways plus the alveoli, okay? So dynamic compliance is not just airways alone. Dynamic compliance is airways and alveoli, okay? Both of them together, all right? Now, examples of dynamic compliance, when we're talking about airway diseases and things that would decrease your dynamic compliance would be your airway diseases and your alveoli diseases. So we're talking about things such as asthma, any type of bronchospasm. So sometimes patients go into a bronchospasm that don't necessarily have asthma, okay? That's going to cause your airways to get smaller. It's going to lead to a higher peak inspiratory pressure. And it's going to lead to a decreasing dynamic compliance. Also, any type of airway obstruction would increase your airway resistance, would cause your PIPs to go up, and would result in a decreasing dynamic compliance, okay? Now, I put that over here on the side because I want you to understand you can't talk about dynamic compliance, or you can talk about dynamic compliance, but you can't understand and grasp the concept of dynamic compliance if you don't understand the role that airway resistance plays in it. So anytime you have a patient with an increased airway resistance, asthma, bronchospasm, airway obstruction, that is going to directly affect your dynamic compliance and push it down. Okay? Now, I said asthma, bronchospasm, airway obstruction. But remember, dynamic compliance is also alveoli. So it's also the change in pressure for a set tidal volume that results at the alveoli level. And so when you say asthma, bronchospasm, and airway obstruction for dynamic compliance, you also have to understand that it is also, so I put and, all of these. Excuse me. Excuse me. So it's not just our airway diseases, it is also our parenchymal diseases, pneumonia, pleural effusion, atelectasis. Static compliance, only alveoli diseases. Dynamic compliance, airway diseases, and diseases that affect the alveoli. Okay? So that's the starting point to understanding dynamic and static compliance. Now, I'm going to take this in to another level for you because I want to make sure you get this concept. So I'm going to put back up here dynamic versus static. Not sure why I erased it in the first place, but I did, so I'll just put it back up there. Okay, so here we go. Dynamic, first of all, you have to know your formulas, okay? So I'm going to point out a key difference here, and this is going to help drive home what we just talked about. Airway plus alveoli versus alveoli only, okay? So our formulas here are tidal volume divided by PIP minus PEEP. Okay? On static, our formula is tidal volume divided by plat minus PEEP. Okay? Those formulas almost look identical, right? Almost. The only difference is with dynamic, you're talking peak inspiratory pressure. With static, you're talking your plateau pressure. Now remember, how do you get a plateau? You have to do an inspiratory hold. What happens when you do an inspiratory hold? You do breath hold. A machine breath is given. You do a manual inspiratory hold, and it settles the air in. Where is that air at now? Is the air moving? No. The air is not moving anymore. The air is settled in and has become stationary in the alveoli, and you're going to measure that pressure. Okay? Remember, alveoli only. There's no airways in this because there's no air moving. That's why we use plateau pressure. Over here with dynamic, you're talking airways and alveoli. So you have to understand that as the air moves through the airways, then you're going to generate a higher PIP. And that's why we use that. You can't assess airways without assessing your dynamic compliance or your raw, which is going to use your PIP as that formula. Okay? Now, what we're going to do now is show you what this looks like on a graph. Okay? So if you understand airways and alveoli is dynamic, alveoli only is static, we use plat for static, we use PIP for dynamic, then we can make sense of this by looking at our pressure waveforms. Okay? And so let me take this off here because I need lots of room. I don't have a big enough whiteboard if you can't tell. So if your normal pressure waveform looks something like this, okay? And I don't have any PEEP on here, so we're just going to start from baseline, okay, just to keep it simple, okay? Then your dynamic compliance is going to be based off of your peak inspiratory pressure. So this pressure right here, okay? On static, your pressure comes up, you do a breath hold, and it returns to baseline, right? So static compliance is based off of this pressure right here on your plateau portion of your pressure waveform. Okay? Does that make sense? So now let's look at a change. All right. Let's look at a worsening dynamic compliance. So next breath comes in, you get a sharp rise in your peak, but your plateau stays where it was. It doesn't go up. So you see here, this is now your PIP that you're going to be using to determine your dynamic compliance. Now, if this is PIP, this is plat, you can see how you can have a worsening airway resistance problem, okay, without a worsening alveoli problem. So you can have a decreasing dynamic compliance without a decreasing static compliance, because obviously our plateau pressure stayed in the normal range where it was, and our peak and pressures have risen, okay? So this will result in a decrease in dynamic compliance, okay? Now when we look at static, we'll see something different. If you have an alveoli problem, you're going to see your waveform do something like this. Okay? Now look what happened. Our plateau pressure has now risen. Okay, so now we're talking plateaus up here. They were down here, so they've gone up. Our plateau pressures have increased by roughly that much. So now you're going to have a decreasing static compliance. Now, this is key. What also happened as our plateaus rose? Our plateaus went up, and so did our PIP from here to here, right? That also rose. What happens if PIP goes up? If PIP goes up, dynamic compliance goes down. What happens when plateau pressure goes up? Static compliance goes down. Now the key to understanding this is this. PIP always greater than plat. Always. You cannot have, watch this, you cannot have this on your pressure waveform. You can't call that your PIP and that's your plat, okay? Your PIP is always above your plat. It has to be, because it takes pressure to get through the airways. And so that pressure is always going to lead to a PIP that is greater than your plateau pressure, okay? This is a common mistake that I see students make, actually quite commonly, like a lot of times. You know, they'll tell me that their PIP was 20, but their plat was 24. That's impossible. It cannot happen like that. Your PIP is always greater than your plat. And if your PIP is always greater than your plat, then your dynamic is always less than your static. Okay? They only works like that. That's the formula, guys. If you divide tidal volume by PIP minus PIP minus PEEP, and you divide your tidal volume by plateau minus PEEP, then you will always get a smaller dynamic than you will on your static. It cannot be the other way around. Okay? So put that in your mind. PIP is always greater than plat. Therefore, dynamic is always less than static compliance. Always. Okay? So, looking back here we have a decreasing static compliance, which is also going to result in a decreasing dynamic compliance. Okay? Over here in this example, we have an increasing PIP, but our plat is remaining the same. And so here we only have a decreasing dynamic compliance. Okay? Talking about static compliance, you have pneumonia, pleural effusion, atelectasis. Something over here, you need to re-recruit affected alveoli. To where in this example, you need to give a bronchodilator, maybe suction your patient. You have some sort of airway obstruction that needs to be cleared out. So, this one just needs the airways reopened back up, whether it's a bronchodilator or suctioning, or whatever the obstruction is. Maybe you have to do a bronchoscopy and go out there and remove an aspirated foreign body or something. But that's what this looks like. The alveoli are not affected. They're unaffected right here. Okay? Here, you see your PIP up and your plateau the same, so you have a decreasing dynamic compliance and unaffected static compliance. Now, while we're talking about this, remember I told you that dynamic compliance, always, to truly understand it, you have to incorporate and understand airway resistance, right? Well, watch this. This difference, remember your airway resistance formula? Your raw equals PIP minus plat divided by flow in liters per second. Well, guess what, guys? That's a visual right here. This right here is your airway resistance. It's a visual. You can see it. The big drop from your PIP to your plat indicates an airway resistance problem, which is why your dynamic compliance sucks. Okay? Over here, is this gap enlarged? Absolutely not, right? So do we have an airway resistance problem over here? Absolutely not. We have an alveoli problem. Our airways are unaffected. Don't give this guy albuterol. It's not going to do anything because it's not an airway resistance problem. Okay? Now, this is my take home. This is my key to understanding compliance. Static versus dynamic. It's this exercise right here. I'll leave you with this, and then I'll open it up to you asking questions for clarification. Okay? I'm going to erase all of this, and we're just going to put a couple of examples on the board, and I want you to tell me what the problem is. Okay? So, here we go. I'm going to do 3 examples. So, let's say you're working a 12-hour shift, and throughout that 12-hour shift, you notice this on your patient. So, at the beginning of the day, it looked like this. As the day goes on, it looks like this. Okay? Question number 1. What's the problem? And the answer is you have a decreasing. Well, the way you have to think about this is your plateau and your PIP have both increased. This is an alveolar problem. Do you have an airway resistance problem? Assess this drop right here. Is it enlarged? No. So you don't have an airway resistance problem. You just have an alveolar problem here. Okay? Which means alveoli affects what? Static and dynamic. So this is a decreasing static and a decreasing dynamic. No airway resistance problem. Let's look at this one. Okay, I walk in, taking care of this patient for 12 hours. You walk in and you notice that your patient seems agitated. They have coarse crackles throughout, and you look at your waveforms and you notice this. You do an inspiratory hold and you calculate your compliances, and guess what? This is what you see. Okay, now remember, right off the bat, you already know the answer to this, right? Right off the bat, you already know, because of this big drop, okay, that your PIPs have gone up, your plats stayed the same. This tells you there's an increased airway resistance, and this patient is going to present with a decreased dynamic compliance only. That's it. It's only a decreasing dynamic compliance, okay? Your static compliance will stay unaffected because your plateau pressures have not changed. Okay? Does that make sense? All right. Last one. 12-hour shift starts. And you notice this. Now, question number 1. Do you notice an increase in your airway resistance? And the answer should be yes. This gap here is greater than this gap, and that's increased raw. Remember our formula, right? PIP minus plat. That's saying you take this number and you take this number and you subtract them. And that's your airway resistance divided by flow in liters per second. So has that increased? Yes. So we already know that this patient is going to have a decreasing dynamic compliance. Now, what about our plateau pressures? Are they the same or have they increased? They started here, so they've also gone up. So because your plateau pressure has gone up, then you also have a decreasing in static compliance. Now, this patient has a worsening parenchymal problem. The alveoli are getting worse. Okay, so it may have a developing pleural effusion, atelectasis, pneumonia, something that's caused this up from where we were here. Okay, but since your airway resistance is increasing, you also need to address the airway resistance. Okay, so understand that there's times when your dynamic compliance is the only problem. That is always an airway resistance problem. If you ever have a decreasing static, you will also have a decreasing dynamic, but you have to look at the airway resistance to know what the problem is. So up here, this is alveoli only. Okay? Talking about the problem. This is our airway resistance problem only. So treat the airway resistance, suction, bronchodilator, whatever you need to do. Here we have alveoli and an increasing raw problem, and you got to figure out how to treat both of them. This dynamic, look, seriously, dynamic and static compliance is a topic that can be talked about for days. This is not a 10-minute topic because it gets so complicated to truly being able to understand how they look and being able to diagnose and look at it from this perspective. Okay, now remember when you're looking at this, if you're looking back, these are all our pressure waveforms. Okay, these are not flow or volume. They look completely different. So first of all, understand that these are your pressure waveforms. And this is a quick way to be able to look at your graphics and use them to assess your changing status of your patient. Okay, so let's recap this real quick. We're going to start with dynamic compliance. Dynamic compliance. Airways and alveolar problems will cause a decreasing in your dynamic compliance. So that's anything that causes an increase in airway resistance, asthma, bronchospasm, obstruction, and anything that affects the alveoli, pneumonia, pleural effusion, atelectasis, and others. Okay? Static compliance is alveoli only. No airway resistance is not a part of that problem, that formula, okay? So it's only alveoli, pneumonia, pleural effusion, atelectasis, and other alveolar diseases, okay? Remember this, PIP is always greater than plat. Therefore, dynamic is always less than static compliance. That's your first clue in knowing you did this wrong. Your dynamic compliance is always, every single time, less than your static compliance, okay? And then look at your airway graphics to help understand if you have an airway resistance problem or just an alveoli problem. Hey guys, I hope this helped. Throw up your comments. I'll respond to them, clarify anything that came across as not clear, okay? So hope you guys will have a good day, and we'll see you soon.